Welcome to today's podcast, where we explore the complex and evolving topic of concussions in sport. And this issue touches athletes at all levels and has received a lot of media attention, especially over the last few years. So joining us today is GSMC's concussion and vestibular physio, Megan, who is at the forefront in shaping national guidelines for concussion management. And today we'll unpack what makes concussions so challenging to manage, discuss myths and misconceptions, and highlight the importance of seeking specialist care. So, all right, so let's dive in. And she joins us now, Megan. Thanks so much for joining us on the podcast. Great to have you. Your background's so interesting in concussions. Can you tell us a little bit about it, what you've been involved with and you continue to do?
Yeah, sure. So, I've been working in the physio field for over 20 years now, and my background has always been in neuro rehab, so that's to do with the brain. So I've always been very interested in the brain, traumatic brain injury. And in 2015, I went to the States to do some training in the vestibular system and visited a bunch of different centres at that time. And one of them was a concussion clinic. And I sat there going, why is no one doing this in Melbourne? Like, they had a multidisciplinary clinic. It was the same as what we were doing for the more severe traumatic brain injury and the team approach. But you have to do things a bit differently with concussion. And so I could see that there was a need that was not being met in Melbourne. So then went back, and myself with some other people within the clinic at Epworth, we set up the first multidisciplinary concussion clinic. We think in Australia, from what we could work out.
You'll claim it, Meg.
Yeah, we'll claim it. Definitely in Victoria.
That was in 2015.
2015 was the visit. 2016 was when we started the clinic. Yeah.
So 9 years ago.
Yeah, exactly. Yeah. And so with that, I just delved deep into the concussion research, which really there wasn't actually that much at that time. Yeah. It's really accelerated over the last 10 years. And so then being a part of forming that clinic and then developing that clinic until I departed at the start of this year, and we'd gone through hundreds, if not thousands of patients there. And then I've also been moved into private practice as well, which is what I'm doing at GSMC. And so then as part of that, I've been back to the States a couple of times and also to Berlin, the Concussion in Sports Consensus Statement meeting, which was in 2022. And in this year, I've been involved in the Australian Physiotherapy Association concussion group, where we've been helping give some feedback to the development of the AIS concussion in sport guidelines, which were released at the start of this year. So that's all been pretty exciting as well.
Very exciting. And you do international travel. That's fantastic. When we talk about the organisations involved in some of those meetings, who are we talking about? What sort of level are we talking about in there?
So if you look at like the Concussion in Sport group, or the CISG as it's known of, they are like the highest level doctors, researchers, neuropsychologists, physiotherapists, everyone. They're the highest level in concussion treatment and research who are meeting at those meetings. And they have people before the meetings who are going through all of the concussion literature that's been released, and they're looking at that with a fine-tooth comb from how valid is the research, how strongly has it been performed. And then from those research results, they're then making recommendations about how we should be managing concussion. And so that particular, the CISG group, they meet every 4 years, and that's been going since the early 2000s, and it's just been getting bigger and bigger and bigger. And then each 4 years they release new statement about, okay, this is from the research how we think we should be approaching concussion management and treatment now.
Mm-hmm.
Yeah.
In each particular sport or occupation, like there's such a vast array of concussions that can be identified. So how did that group specify into each of the sporting governing bodies?
Yeah, look, they try and make the guidelines overall generalised, not just to sport, but also to location. So they try and take into consideration that, look, there can be people in third world countries who are picking up these guidelines and trying to use them, and people's in all sorts of sports. So they actually try and make the guidelines as generalisable as possible, so that then if people don't have, electronic testing resources, we can still do a really good job at assessing and managing concussion with a little money, really.
Yep. Fair enough.
Yeah.
If we break it down, Megan, what is concussion?
Yeah, so I mean, the concussion in sport
go
group
for it now.
have
Yeah, unleash.
Yeah, just go for it.
I think one of the concussion in sport group have a definition in their release that they've done, and it really involves that there's a blow to the head or the body, so it doesn't even have to be the head; it can be a blow to the body, that then causes a force to be transmitted through the brain, and so it's that force going through the brain that then creates shearing of or a stretching of axons in the brain. So I like to describe it as there being just very on a basic level 2 layers of the brain, and you've got little neurons. So imagine little threads of cotton going between the 2 layers. And then when there's that force that goes through the brain, one of the layers is heavier, so it moves faster than the other layer. And so one layer moves differently to the other across, and that stretches all those little bits of cotton, the neurons or the axons. And then when they're stretched, that then releases it causes the neurons to fire when they wouldn't normally. And so within the brain, you have millions of neurons all firing at once, when normally we wouldn't have that many neurons firing at once. So it creates effectively an electrical storm within the brain. And that can be when you might see on the ground people either losing consciousness is a really big example, but you might see people falling down or being really vague or stumbling, losing balance. All of those things are happening because of that electrical storm within the brain. And that is a momentary storm, but then after that storm passes, we have a situation where the cells in the brain have used a lot of energy, and they actually are misusing energy, or they're using energy in a way that is not very efficient afterwards. And it can actually, over the next few days, create more energy deficit within the brain. So we actually see the lowest point around 3 to 5 days post-injury. So there's an initial electrical storm and then an energy deficit afterwards that we're then waiting for that to recover.
And we'll go into that in a bit more detail, but that 2 to 3 days post-concussion is crucial, isn't it?
Oh, absolutely. Yeah.
In regards to the management, how you go about it, the medical side of things, which we'll touch on down the track, and the process of getting that player or athlete or worker back to what they want to be able to do.
Yeah, I think one of the biggest things about concussion is getting that initial management right, like, on the field at the time, and then the 48 hours afterwards, and then those few days and weeks as the cells are recovering, because that's really what we're looking for, is cellular recovery within the brain. And we're wanting that recovery process to be complete before someone is going back to being in a situation, i.e. sport, where they could have another knock to the head. So that's really what we're looking at from a concussion recovery, is let's get the brain working the same as it was before we get someone where they're going to bang their head again.
And that's the most crucial part as physios or medical management or sports trainers or anyone on the sideline. It's that identification straight away.
Absolutely.
Like if you can identify whether it's a head knock, a blow to the body, whether there's been some sort of incident, they can have that long-lasting 2-3 days after that they can start to show some signs of concussion, which is most important from our side of things. So you've got to go through the process. And you were saying only 2015 that there was only first concussions.
Multidisciplinary concussion clinic,
That astounds me, for the fact is we've been playing particularly football, netball, horse riding, surfing, running, occupational injuries for years prior to that. So obviously it hasn't been well managed, and now there's more media and more presentation out there in regards to AFL players particularly. The identification's the key.
Yeah, absolutely. And then the initial treatment, and let's get that initial management right. And then I think that we'll see concussions don't become a big burden later on if we're managing them really well at the start.
So acute versus chronic versus other types of concussions. Can you sort of get into that side of things?
Yeah, sure. So what we've just been talking about is what we call the acute, so when the incident initially happens. And what we understand now is that it's actually really normal for people to take as long as 4 weeks, that's both adults and children, for their brain to be recovered in that acute phase. So we would still call that first 4 weeks an acute concussion. And then once people are moving past the 4 weeks, we know that depending on what statistics you're looking at, around 30% of people will actually have symptoms after the 4-week time frame. And so that's when we start to call it persistent concussion symptoms. It has also been known as post-concussion syndrome, but those of us in the area, we really don't like that terminology because it tends to indicate that it's a permanent problem. So that's why we prefer calling it persistent concussion symptoms, because it's symptoms that can be treated so people can recover from that. And so that's after the 4 months. So in short, I would say PCS, persistent concussion symptoms. So I deal a lot with that, and we're looking at treating those symptoms. There's heaps that can be done from a rehab perspective. And then I think you might be also alluding to if I don't think we can do a talk on concussion without mentioning CTE because it is so forward in the media and often concussion and CTE get paired together in the media, which is not necessarily appropriate. So do you want me to go into CTE? What is it?
Maybe just describe what is it. I think just so people
for
can
the layman
recognise
person out there.
and differentiate between the two, but just in its basic form. Megan, what is CTE?
Yeah, so CTE is chronic traumatic encephalopathy.
Well said.
Well done.
That's why we
It
call it
is
CTE.
Definitely a tongue twister. And so it's a progressive neurological condition. So when we say that, it's neurological, so affecting the nerves, or in this case the brain, and progressive meaning that it gets worse over time. And it's got a really specific neuropathological pattern, which means that if a scientist were to cut up the brain and look at it under a microscope, they will see very specific changes in that brain tissue. And so they talk about it as being a tauopathy. So really looking at tau deposition. So it's just, if you imagine little bits of grime being developed by the brain itself and then it kind of sticking in certain parts of the brain, which is then affecting how the brain is functioning. That's kind of a really simple way of looking at it. And as I said, they look at it under slices of the microscope. So it's actually diagnosed only after someone has passed away, which makes it really tricky.
Difficult. Yeah,
because
100%.
it's got lots of symptoms, so a lot of like cognitive, so forgetfulness, difficulty concentrating, higher level thinking, problem solving, but also sort of being impulsive and anger and aggression. They can be a lot of the symptoms associated with it. But those symptoms can also be associated with lots of other neurological conditions. So your anxiety, depression, certain types of dementia, Alzheimer's, there are lots of other neurological things that can be causing those symptoms, which then makes it really hard. If someone says, oh, I've got all of these symptoms, maybe I've got CTE, they could actually have other things. And that's why it's so important to actually see specialist neurologists, psychiatrists who know more about how to assess that and try and see, because there can be treatments for those things. So we would hate for someone to be thinking, oh, I had a bunch of concussions, therefore I have CTE. It's certainly not a direct causation. What we know with CTE is it comes on later. So generally they talk about at least 8 to 10 years after someone has finished playing. They would have symptoms later on down the track. And there's also not a direct correlation between number of concussions and how likely someone is to get CTE. So someone might have had, 20 concussions. That does not mean that they are definitely going to get CTE.
And that's very important to sort of reiterate to the public out there that it doesn't lead to CTE. That's the most important part.
Absolutely. And I think, a lot of the research with CTE, they talk about not just concussions, but what's called subconcussive blows. And so what that means is knocks to the head that haven't actually been big enough to cause a concussion. And so some of the research, at the moment, they're looking a lot at correlations. So they're sort of looking at people's history, and then once they get that diagnosis after they've passed away of CTE, they're then looking back and trying to work out what can they see that's common between people. So one of the things I looked at in professional UK soccer players, the stats were something around 5,000 knocks to the head over their playing career.
That's with the headbutt for the ball.
Yep. So doing their headers, and because they were like through the 80s and 90s, they'd spend an hour at a training doing headers on a possibly wet ball, and so that's
what you're
a lot
talking
of
about,
knocks.
The
subconcussive blows, exactly.
And they could be knocking your head getting into the car, truck drivers getting into the car, all that
It
sort of stuff.
still needs to be fairly decent.
But there's many things that could potentially do that.
Yeah, and look, I think we really need to acknowledge general brain health too. If someone's going out having many drinks, many nights over many years, that's going to be very detrimental to their brain. Poor
100%.
nutrition,
Yeah.
not exercising generally.
Yep.
So we can't, we need to really take a more of a holistic approach to how we're looking at how is our brain health over time.
Yeah. And I think even some of those things we just talk about now, whether it be what you were just saying, Megan, as part of growing up, and a lot of sports probably use that sometimes as a badge of honour.
100%.
Playing football, whether it be male, female, whatever it is, soccer's not something you really correlate it to, but you can. So are we getting better at that, Megan, do you think? In terms of understanding potentially, hey, hang on, this has got some repercussions. How can we sort of start to think differently about this?
I do think we are. I think that it is a cultural change in terms of concussion management more than anything else. So I feel like at the moment we are in a period of adjustment and change. I tend to liken it a little bit to smoking and society's understanding of smoking. I love to pull out the old fact that apparently doctors used to advise asthmatics to smoke menthol cigarettes to help clear their lungs.
Perfect. Working on their airways.
And so now, we laugh because
This is what I mean.
it's so ridiculous.
And even going back to the sporting side of things, that being a physio around for a long time, if you came off with a head knock, you'd be considered soft.
Exactly.
And you need to get back out there, and your team needs you, and they might be dizzy and they might have a headache. They might never know where they are. But at the end of the day, like you've played footy, I've played footy, you come off for an invisible injury, you're no good to anyone. So that's why, particularly back in the day when I was doing sort of elite sport, we were told to put them back on, which was nervous. But we had no idea about concussion back then. It was just like, oh, yeah, you got a head knock, get back out there, you'll be right tomorrow, away you go. Be different if you had a hamstring tear or you broke your leg. You physically can't get out there. So you can actually feel it and see it. But the head knock, the blow, the symptoms that you can get from concussions, back in the day, get back out there.
Yeah.
It was one of those, as you said, badge of honour.
Yeah.
And as a medical practitioner on the sideline, we were responsible for putting those players back out there to a certain degree.
Your name's on that.
Yeah, absolutely. And now coaches now are more aware of that. They understand it because of the media, the publicity beside it with the AFL and everything like that, which is great because everyone gets that awareness. And the more aware we become with the management and the on-field management, the better the player and the athlete will be.
Yeah.
Yeah, absolutely. And I do think that, we've still got some coaches and players out there.
And parents.
Who are of the older
Old
way
school.
of thought of, there's certainly some who, I just went back on, I was fine, nothing wrong with me. But I think the younger players coming through and a lot of their parents have better understanding. And which is good because then they're going, I'm coming off. I had a head knock. I don't feel right. I'm actually going to take myself off. I'm going to make sure I do the right things. And that's actually what we want is just good management. So it's good that it's changing.
Yep, absolutely.
And if they haven't recognised it, Megan, but what can parents do if they're, or coaches on the sidelines who may be seeing some things that the player might be reluctant to come off? So unless they're putting their hand up saying, hey, I don't feel well, that's a different story. But if parents are watching their kids play sport or coaches, what are some of the things that they can potentially see in them that might raise some red flags?
Yeah, absolutely. Because there can actually be times when someone has a concussion and because their brain is not thinking clearly, they don't recognise that there's something wrong. They can think that they're fine when they're actually not. And so as an outsider, you're really looking for things like, are they stumbling around? Is their performance the same as normal? Are they like dropping balls when they wouldn't have? And this would be after there has been a bump that has been witnessed. Sometimes you'll see people playing the wrong way, so they'll kick the ball to the wrong direction. So it's looking at those sorts of things and then sending out, if you're not sure, send the trainer out. So check in with them, have a conversation. And there's these things called Maddox questions, which are very much about what day is it, what team are we playing, what end are we up, those sorts of things to get an idea of are they clear in their thinking and know what's going on and where they're at. So they would be the things. But if they keep like clutching their head, rubbing their head, things like that, they'd be signs that you go to check them out.
Yep. And within that 48-hour period, as we were discussing before, what can parents do with their kids in terms of that crucial time frame?
Yeah, look, I think the number one thing that we need to be really aware of is that after a head knock, there can be more serious consequences than a concussion, and that being a brain bleed.
Mm-hmm.
And so we really want to make sure that that is not a situation. So if there are any concerns, and some of the things we're looking for are the person who's had the head knock getting more and more drowsy, becoming more clumsy, starting to vomit, so, increasing headache that's just going up and up. Some of those can be signs of a brain bleed. So I'd always say straight to an emergency department if there are any of those signs. So we want to just make sure that medically everything's managed well right from the start. Once we've got that sort of crossed off and we know that that's not the situation from a concussion perspective, you're really wanting to be just having relative rest in the first 24 to 48 hours. So there used to be a thought that you would wake them up overnight, and that was really around checking that they haven't had a brain bleed. That was why. What the feeling is now is that they actually need to sleep to help the brain to recover. So the onus is then on the parents to go and check. So they get to wake up overnight. But just go in and check. The kids hasn't vomited. They seem to be breathing at a really regular rate. They're okay. So check on them overnight. Allow them to just hang out around the house. And then after the first 24 hours, they can start going for little walks, because we actually want them to be doing what we call symptom-limited activity. So they can do anything that they want that is not going to risk a head knock. That only increases their symptoms by, if we're using a 10-point scale, by 2 points. So I always say 0 would be you've got no symptoms. 10 is the worst possible that you can think of for your headaches or nausea or dizziness. So if they do something and their symptoms go up by about 2, then they just stop and have a bit more of a rest. We don't really want them sleeping throughout the day. We want to try and keep them in a good sleep-wake cycle, but just hanging around. We also don't want them on the screen heaps. There has been some good research showing the first 48 hours they're better to avoid screens. But then after that, they can start using them again, using that symptom-limited activity approach. So they might spend 5 minutes on their phone and then feel a bit yuck, so they have to put it down. So it's really that rest first, then get moving. And then the other thing would be really good nutrition. So making sure that they're eating lots of veggies and everything, good hydration. And you actually really want to keep that up for at least 6 weeks to help the body be able to recover after concussion.
So after they're medically cleared, when would be the best time to start with you as a vestibular concussion physio?
Yeah, so I will see people even if they've had a concussion on the Saturday. I'll see them on the Monday. And a lot of that often with students is around planning, and advising and just checking in, how are they going? And it's much more like, okay, this is what you can do from an activity perspective, depending on how they are. Some of them are more symptomatic and others are really not very symptomatic by that stage. So it's a lot of advice about that, and then advice about return to school as well, because we don't want people to jump straight back into school full time because it can be too much for the brain to have to deal with. So I can help them out with, here's a graded return to school program, depending on this individual person, what symptoms they've got, what their school commitments are, and then we progress that over a few weeks. And then normally I tend to see people about weekly, unless they've got lots of neck issues. So sometimes with a knock to the head, you can get a real whiplash. So we need to treat that, and that's good to look at as well to see in that first week, have we got neck issues going on that need treating?
Is there differences between male and female athletes with a concussion?
Yeah, so the statistics are quite interesting. There can be more concussions with females, and females can be more likely to have more persistent symptoms as well. So we in the statistics are seeing a difference,
Why is that? What do you reckon?
There are a lot of hypotheses.
It's the same thing with ACLs with the women in sport, particularly football. So what would be some of the myths or the conceptions in regards to females getting more concussions or less concussions? Or
Well, I'll talk about hypotheses rather than myths.
Love it.
So some of the hypotheses are around women being more likely to have longer necks and thinner necks. So the idea there is that when the blow comes, the neck muscles are not able to stabilize the head so much. So then there's more movement of the head and thus a greater force going through the brain. That's one hypothesis. Another is to do with how a female brain is actually structured neuroanatomically. So there's been some research indicating that the axons, which are the little cells, the threads that we were talking about at the start, are thinner in females. So then that stretching force can create more problems. That's one hypothesis. Another is around the hormonal menstrual cycle. So they've had some research that has shown, depending on what stage the female is in their menstrual cycle when they sustain their concussion, that can actually then influence how easy it is for them to recover. And then there are also some hypotheses around females just being more honest than males. And so whether that
It's a better reporting.
Yes, and the females are actually saying, I don't feel great, I've had a concussion, whereas the males are not. And then that, when they're collecting their statistics, they're going tick, tick, more females than males have reported concussions. So lots of hypotheses, not 100% sure. And the other one that I wanted to discuss as well was playing style, which we're particularly seeing in community AFL because it's been such a newer sport, and particularly like you older teenagers or young women who have taken it on as a sport at that stage but haven't grown up playing it and might not have actually been well trained in how to protect their body when they're going in for the tackles.
And that's definitely shown in the AFLW. It's televised 3, 4, 5 years ago. Everyone used to go in head first.
Yeah.
But now they know how to evade, they know how to protect themselves, they don't put their head in the ball. So it's definitely probably getting less in regards to their style
I think
of play.
it's changing heaps. Yeah. And I don't know if I should admit this, but I actually played 20 years ago.
Yeah, right.
And took it up at uni, and my husband said that we were just dangerous.
Yeah.
Because he said, you're all so enthusiastic, but you've got no idea.
Correct. And I think in another 10 years' time, the time the Oz kickers come through, they'll be that much more better.
Yeah, and they are. Like, I mean, we saw whilst I was playing, there were some of the girls who were 15 who joined our adult teams because there were no teams they were allowed to play with, but they had grown up. So they'd played footy with the boys until they were about 12. Then they'd been kicked out because there were no leagues they were allowed to play in, and then they joined us as youngsters, and they were miles better than us.
Or their brothers playing in the backyard or something like that. So,
but I think because they'd grown up playing it, they'd 100%. Been better trained at protecting their body. So I think that's really changing a lot now. But has been part of, research. You're always collecting data from however many years before.
Do you think the AFL's doing enough, Megan, in terms of not so much promoting it, but being active around what they're recognising and then putting their protocols in place? Just exactly what you were saying then, Nick. I know footballers in the last potentially, say, 10 years or maybe even 5 years have had to adjust how they attack a contest, using their body a lot more, positioning these sorts of things when it's a ground ball. So from a player point of view, I think they're a lot better at it. But is that an AFL direction, or is it something that they've just adjusted to? And if the AFL can do more, what would you like to see from an AFL point of view to do some more around the whole issue?
Yeah, so there are a few different components in that question there.
Feel free to pick that apart and go where you want to go with it.
So in terms of whether the AFL have told the players to change how they're playing, I'm not 100% sure. I don't have insights as to whether that's come from the top. I do think that the AFL are trying really hard, and I know that the people who are involved in looking at concussion within the AFL, they're like really high-level researchers and doctors and neuropsychologists. So they're on the panel at the Concussion in Sports group, consensus meetings. They really know their stuff. So these people who are trying to then set up the policies for AFL, they are on top of the research. And what the decisions that they're making, my take on it, is that they're trying to incorporate what we're understanding from the research and how the research is evolving with a game that has been going for a very long time, has a certain culture, and has a very big public who are watching and very happy to comment on any changes that are made. And I think they're in a really hard position because it's sort of, they try and extend the time frames for people not being able to play and they get criticised for that. but then they also get criticised for not doing enough. So how do you win in that sort of situation?
Yeah, it's going to be an evolving beast in regards to that side of things. And that comes back to that time frames that we were just talking about. The reporting coming into finals. We find that people, particularly probably the guys, won't report as much because they don't want to miss out on the finals. So that's going to have a massive impact in regards to concussion management and honesty. So we tend to find that may work, may not work, and I think they just have to have a ground rule that it is what it is. And I think it, particularly in the AFL Barwon sort of area, I think it's taken up pretty well.
Yeah. And look, it's all about actually protecting the player. That's where, so all the guidelines, the community AFL guidelines, it's very much taken from scientific research that we actually know that it takes the brain longer to recover than when you stop having symptoms. We're looking more at least 14 days for the brain to then recover, particularly in your adolescence, after someone finishes having symptoms. And that's why they've extended out the timeframes with the AFL policy. It's really to take care of people and to try and make sure that then they're going back into the sport fully healthy with no problems. And I think, there's a condition that is rare but very serious, which is called second impact syndrome. And that is where if someone's brain is still recovering from a concussion, but at a cellular level it hasn't fully recovered, and then someone has another knock again, that electrical storm that happens within the concussion, it is so massive that the brain actually becomes overwhelmed and has massive swelling and the person passes away.
Wow.
So it's a very
Nasty.
serious consequence. And so we're really just wanting to protect people. And, it's not fun to miss a few weeks, particularly finals. It's not fun. It's not what people want to do. But we're also trying to make sure that you've
The duty of care.
got another life. You've got a life to
Yep.
be able to keep living.
Yep.
And that's what it's really coming down to.
Is an option to wear helmets, and they've spoken about it for a very long time. Is that an option? And if it is there any comparisons with or without helmets, Megan? Is there much of a difference with a head knock?
Yeah, so the literature at the moment really isn't giving us any indication that helmets are useful in terms of preventing a concussion. And if you go back to when I explained concussion at the start, it's about that force being transferred through the brain that is what's creating the problem. And so whether you've got a helmet on or not, the force is still going through the brain. So at this point in time, the literature is pointing towards doesn't really make a difference. There was one article that was published a while ago where they were looking more at kids and adolescents, and they showed that some of the kids played harder when they were wearing a helmet, so they were actually more dangerous. And that other players on the opposition were going after the kids with a helmet more. So again, they were being put in more danger from that respect. The way I look at it is if someone feels that they feel more comfortable wearing a helmet, it's most of the time it's not detrimental as long as they're mindful of their own play style and they don't change how they're playing, whether they're wearing a helmet or not. But if they do find themselves getting targeted, then that's not a positive at all.
As you said, it's not, the young athlete will probably think that they're protected.
Yeah.
They'll go in harder, create more of a concussion. Like Angus Brayshaw, he used to wear a helmet.
Yeah.
He got ruled out.
Yeah.
Was medically unfit.
Yeah. And so I do think it's an area that we're still evolving with the research. So, 5 years from now, we might have different types of helmets. There might be different research that's been done, and it's a different answer that I give to that question.
Yeah. Fair enough. This is a strange one. It could be very obvious, but do you actually have to have a head knock to have a concussion?
As I said at the start, it can be a knock to the body.
Yeah, so describe that. So talk about what that looks like. Is that from a whiplash perspective or what is that?
Yeah, so it's both. Whiplash can be part of it because a lot of the symptoms we see in concussion, they also can be really similar or the same symptoms in whiplash. And that's where it can be really tricky. Is it a concussion or is it just a whiplash? So there's one component is whiplash. So if let's say you've had a really big knock to the body, but your head doesn't actually get hit at any stage. So an example of that I see tends to be people in cars. So they've got their seatbelt on, so they've had a really massive impact to the car, but the head itself hasn't knocked against something, but their body has. So there's been a big force. And so in that situation, there can be the whiplash, but there's also that force that goes through the body is going to go through the entire body, not just your shoulder or body, or go through the head as well. And if there's enough force in that to be able to then create that movement of the two layers of the brain, then that can create that concussion.
And that's different to manage because it's not visible. So unless you're feeling the symptoms, I'm assuming, how do you then treat that if you haven't seen the head blow? Is that more of an honesty thing?
Yeah, look, and this is one of the biggest challenges with concussion. We call it a clinical diagnosis because there is no scan that can say you have had or you have not had a concussion. What we expect is that a CT brain or an MRI brain, it will be normal with a concussion. So if there's something on the brain scan, then we're talking about a more serious traumatic brain injury, okay? So whether it be still a mild traumatic brain injury or whatever the classification is, they're not a concussion. So part of the concussion definition is that there is nothing on the brain scan, okay? So what we're then looking at is there has to have been an event, so a blow to the body or the head, and then it's a cluster of clinical signs and symptoms is what is then looked at by a medical doctor when they're looking to diagnose, has this person had a concussion or not had a concussion? Yeah, so it can be pretty complex, particularly when there's the overlap with whiplash. And we think, well, which one is it? Whiplash, concussion? Yeah.
So if a client came in to see you, what would the expectation of that client to walk into the room, explain they've had an event, how would you diagnose that? How would you treat that? I know it's a pretty long-winded, probably going to be a long-winded question, but and a long-winded answer. But how would you go from initially meeting that client to return him to sport or return him to school?
Yeah.
Is there a bit of a standard process you use, or because of the complexity of concussion, what tools do you use, or what tools do the client going to expect?
Yeah, so look, in terms of diagnosis, there's pretty sure I'm getting the acronym right, the ACRM. It's a American College of Neurologists who have put together some guidelines for diagnosis of mild traumatic brain injury. So concussion fits inside that, as long as there's nothing on the scan. And so they've put together a diagnosis flowchart. So you, as a clinician, you go through that, and then you're saying, does this person meet that diagnosis criteria is first. There's a lot of technicalities within all of the AFL community documentation that only want diagnosis done by a medical doctor, not a physiotherapist, whereas in the AIS, Australian Institute of Sport guidelines, a physiotherapist can diagnose. So we have a few different things going on there. But that aside, I first of all look at, are we looking at a concussion? Whether I'm suspecting that, diagnosing that, and then what are the main things that the person is struggling with? So there can be a lot of different symptoms from a concussion's perspective. We've already mentioned that the neck could be one of those. So then I'm looking at, do they have problems with their neck? Is that one of the primary problems? If so, then I'm looking at treating that as a physiotherapist, really using your physiotherapy techniques, manual handling, exercises, etc. The other things that can be problematic can be the vestibular system. So that's your inner ear balance system. And also looking at how does the brain take information from the inner ear as well as other areas of the body to work out balance. So I'm looking at, do we have balance issues? Do we have dizziness issues? So looking at that component. So assessing that. If there are issues there, then I can give exercises to help with the balance and dizziness. Another area that people can have issues with is what's called the autonomic nervous system. So that's really around controlling heart rate and blood pressure, but also communication with the gut and endocrine system, so at a basic level. And what I see with that sometimes is that people get lightheaded when they try and go for a walk, or they get lightheaded headaches when they try and concentrate. So I'm then assessing that. So I can do some basic testing, treadmill testing, things like that, and be looking at their heart rate. And from those assessments, I can give a really specific prescription of what sort of exercise they can do to help with their rehabilitation. So we know in concussion, as with many things, exercise is medicine. So I can be very prescriptive on what I'm giving with that. So I think, and then the other system I screen is the visual system. So again, people can have issues with their eyes, And sometimes if it's just eye movements, I'll give some exercises. But if it's more in depth and people's symptoms are going on for a longer time, then I'll involve a specialist optometrist. So hopefully that wasn't too...
Yeah, no, perfect. And going back to there's physios and there's physios, we're very fortunate to have yourself and Drew working here. I'm a physio by trade, but there's no chance I would diagnose a concussion or do what you did without having specialty training. But I know there's physios out there that say they are concussion physios. That sort of grinds my gears a bit. Whereas you know you got to go to a specialist in regards to a physio that specialises in vestibular and concussion. Does that sound fair?
Yep.
Yeah. I wouldn't touch concussion. 10-foot pole.
Well, do you know
because I'm not trained at it.
Well, you don't have
and
to.
You need to be trained. And
Yeah.
Megan's gone through a history
Yeah.
of understanding what concussion is and the amount of courses and representation she's done on different guidelines and boards. You need to be good at that craft because it's at the end of the day, as you said, Ben, it's an invisible injury. It's up to the client to report it well, and it's up to Megan and the vestibular and concussion physios to sort of extract that information out through the skills that they've got, rather than just a plain musculoskeletal physio that can technically treat concussion, which we can't.
Yeah, I would say I've done over 1,000 hours of study at least. And I like to joke that thank goodness my husband's an accountant because he can pay for all of my professional development courses. But the other thing I like to say is, would you want your GP to do your heart surgery?
Yeah, spot on.
Or would you prefer a cardiologist to do it?
Yep.
So I think, and some people are kind of doing an online course and going, now I'm a specialist, but it's not the same as doing specialisation in vestibular, specialisation in the cervical spine, specialisation in the neurological side of things. So there's a lot going on with concussion.
And what I've loved about this chat is she's very confident in what she's saying.
100%.
And confidence comes from preparation though, Megan. So as you're saying, you just speak about it so effortlessly and you just roll through it. And it's fantastic for you actually come on here and just explain to not just us, but everyone listening, whether they're a player, a coach, a parent, whatever it looks like for them, they've got such a good insight from someone in the absolute go-to. Right here at GSMC too, Nick, which is
she's a valuable asset to have. And as it comes down to any physio out there, report it, understand what it is, refer off. That's the main component of it.
Yeah. Megan?
Can I just say, I think from my perspective, I just want the concussion awareness to be out in the community because I've treated so many people and they've come in 1 year, 2 years post with so many problems and it's been life-altering for them in a negative way. And so I just really want everyone to be saying, okay, let's do it right at the start. And then let's prevent all of these longer term issues that are causing so many problems for people. So I really just want to be able to help people is my biggest goal.
Absolutely. And if in doubt, sit it out. Pretty much is the end message.
There you
Get
go.
a head knock, go and see a specialist, get cleared, then you can return to sport, return to work safely.
Absolutely.
You want to know any more? GSMC, Megan Hamilton, she's just joined us on the podcast. Megan, thank you so much.
No worries at all. Thanks for having me.
Thanks, mate.
Pleasure.